I am going to talk about Invista Health, which is a UCLA startup that started almost 7 years ago here at UCLA. We all know that the population of the world is aging, including the United States, including our own country, Iran. And in the US, a bit of a statistics would tell you that America 65 plus is projected to increase from around 60 million to 88, 90 million by 2050. So the challenge that is happening here right now is that while we are getting older, we need care, we need more care. And at the same time, we want to have the same quality, if not better, of care. You can see here that Medicare potentially preventable spending is around $40 billion a year, which half of it is being dedicated normally to frail and also another 8 billion to pre-frail population. What we call potentially preventable spending are the adverse events or spending that happens in the clinical setting that could have been easily avoided had we known some information about the patient. We could have predicted it. We could have foreseen it early on in order to avoid it. So what is the solution? Normally, many of you are currently familiar with remote patient monitoring, is to capture, monitor, and capture biomarkers from patients and analyze these biomarkers, assess them early on, in order to be able to use machine learning and artificial intelligence to predict adverse events, so that you could, or clinicians or caregivers could intervene in timely manner. So basically, just summarize monitoring and capturing biomarkers, and then later on, apart from monitoring patients, be able to predict adverse events. So our concentration has been, as I said, mostly on geriatric frail population. We are a platform which is device agnostic, so we can incorporate a series of different hardwares within our infrastructure. One of the proprietary aspects of our system is to have indoor localization, which can provide a better storyline. These are all, you might know that they're all called digital breadcrumbs. So it can provide us a better storyline or better, more comprehensive digital breadcrumbs of the patients. And when we started this company 7 years ago, people barely knew about remote patient monitoring. But now after COVID, it has got more traction. A lot of developers and scientists are flocking into this domain. However, building an ecosystem like this needs a lot of work, needs patient acquisition, needs to be working on patients closely to build this ecosystem around it. It's not that only technology matters, but there are a lot of intricacies involved in something like this. So we have a patented technology, 6 years of clinical validation. So rather than getting out of UCLA, we decided to stay at UCLA to use UCLA patients for clinical validations. We have more than thousands of patient days. We monitored patients, different cohorts of patients that hopefully we get to talk about. And then we waited afterwards for 6 months to a year in order to see what will happen, to see their outcomes, and then build our machine learning models. Not to bore you a lot with the numbers, it's a massive market, $40 billion, which could be, we target to have 10% of the Southern California population, and which would give us 270 million. We are hoping to target only SNFs, skilled nursing facilities, rehabs, and patients at home. The return on investment for a normal SNF or rehab would be 5-to-1, and the ROI for the accountable care organizations or any of the major care providers would be 7-to-1, according to what we have done. Again, I don't want to get into a lot of details, but what we have done, compared our models, built our predictive models, compared it with the risk stratification models at UCLA. We improved the recall twice with having the same specificity. Competitive landscape, more and more coming into the picture, but there are not many who have a scientific backbone and a lot of patient records and who have been able to build their predictive models in the area. And then we are definitely one of the only ones with indoor localization, which happens to be of paramount interest in determining the outcome of patients. As I said, device agnostic, we use FDA cleared devices. We have agreements with companies to provide us number one hardware companies or top hardware companies to provide us with the hardware. And we are, even though we use FDA cleared, we are going for FDA clearance for the platform, which is another added value. So far, we stayed at UCLA and to use our grant money, or approximately more than $2 million we have spent on building this technology since 2015-16. And we are seeking another $2 million that is mostly being spent on deployment, controlled deployment to nursing facilities and patients at home. Exit strategies, mostly such technologies will be expecting to be bought by big players, care providers that are seeking such technologies to improve the efficiency of their systems. We are mostly academicians. My partner and I are both academicians at UCLA. I'm a computer scientist by background. My partner is Associate Dean of Medicine, and we have used a couple other people, mostly in the business aspects and also in the rehabilitation medicine. But ever since this slide, we have added 2-3 more business savvy people to our team. And thanks a lot for giving me the opportunity. I would be happy to answer to your questions through email or here. Thank you.
Thank you.